Hello, everybody. Thank you so much for logging in to our Focus on Glaucoma webinar for the China and the West Pacific region. All the presentations today will be in English and the webinar will be for 1 hour. The International Agency for the Prevention of Blindness, IAPB, the World Glaucoma Association, and the International Center for Eye Health, with support from Allergan, are running Focus on Glaucoma, a new initiative to mark World Glaucoma Week 2019, which is from 10 to 16 March, that is tomorrow. We have presentations today by a very eminent panel. We have Professor Mingguang He, Professor of Ophthalmic Epidemiology, University of Melbourne, and a part of the team at the Center for Eye Research Australia, which is also an IAPB member. So he's heading this webinar for us. And we also have a couple of other panelists. Now, without much ado, I'm passing it on to him. Over to you, Ming.
Thank you, Taja. Good. Today, probably I just start from a little bit introduction on the World Glaucoma Week. Glaucoma Week actually was proposed by the World Glaucoma Association. The World Glaucoma Association in conjunction with the World Glaucoma Patient Association. So the Glaucoma Week has been run for more than 10 years now. It has been very successful. And very gratefully, IAPB has been organizing a webinar specifically looking at glaucoma in China and Western Pacific. Today we're going to have 3 speakers. We're going to focus on different topics related to glaucoma. So let me just try to introduce the speaker for today. Myself is I have been working in. My name is Mingguang. I have been working in China for more than 20 years. And then I joined the faculty at Melbourne University. I work in CIRA as a professor of ophthalmic epidemiology. And then we also have Professor Nathan Congdon. He will speak in Belfast. He also worked in China, in particular, the Zhongshan Ophthalmic Center, for around 5 years, from 2010 to 2015. And we have Professor Zhang Xiulan. Professor Zhang Xiulan is a glaucoma specialist working in the glaucoma service in Zhongshan Ophthalmic Center in Guangzhou, China. Then I followed by about around 10 to 15 minutes presentation, and this presentation will in particular focus on angle-closure glaucoma in terms of magnitude, screening, and prevention. And then Nathan is going to tell us a little bit more about glaucoma in China in his understanding. And Professor Zhang Xiulan will share her knowledge in particular focus on glaucoma service in a tertiary hospital in China. So good. So this is my financial disclosure. When we talk about angle-closure glaucoma, we really have to go back to around 20 years ago. In 2001, the ISGEO as a society published a new definition system for angle-closure. They try to define glaucoma, angle-closure glaucoma in particular, into 3 hypothetical stages: the angle-closure suspect, and primary angle closure and angle closure glaucoma. When we say primary angle closure suspect, really means people are at anatomical risk to develop angle closure. So we are talking about some features in a static gonioscopy changes. For those people who develop peripheral and anterior or anterior synechia in the drainage angle, or somebody might develop IOP elevation, then we start to call them primary angle closure. And primary angle closure glaucoma, in particular glaucoma as a specific term, is restricted to use only for people with established glaucomatous optic disc change or with visual field damage. Again, 15 years ago, we ran the first population-based study published in international peer-reviewed journal, the Li-1 Eye study. This study actually enrolled about 1,500 subjects in the population, from the population. In this particular study, we found out actually in terms of prevalence of glaucoma, the total prevalence of glaucoma is about 3.6%. And primary open-angle glaucoma is about 2.1%, and primary angle closure glaucoma is 1.5%. So the important message from this prevalence data is that even in Chinese population with equal number of open-angle glaucoma and angle closure glaucoma. And more importantly, if you look at this primary angle closure suspect, primary angle closure on PACG, actually around 10% of people, if you add it up together, will have we call it occludable angle. That will including the primary angle closure and primary angle closure glaucoma. So the primary angle closure suspect is around, if you subtract these 2.4% and 1.5% from the total occludable angle, so primary angle closure suspect is about around 6.5% in the Chinese population aged 50 years and older. And primary angle closure is about 2.4, and primary angle closure glaucoma is 1.5. So then when you compare this data with other populations, strikingly, we found out actually in terms of the prevalence of angle closure suspect, primary angle closure glaucoma, when you compare the urban Chinese population in Guangzhou and in Singapore, in Mongolia, they're very similar. Everybody, these three populations got about 6% angle closure suspect and around 2% primary angle closure and around 1.5 or 1% primary angle closure glaucoma. This prevalence of angle closure is considerably higher or greater than any other study performed in the Baltimore, for example, the white population, Baltimore black population, or Italy. So in other words, the Chinese people, they are really anatomically prone to develop angle closure in particular. So in 2001, Paul Foster and his colleagues published a commentary paper in the BJO. They tried to estimate how many patients with glaucoma in China. So they tried to project and estimate the prevalence in rural population using the data in Mongolia, and try to estimate what happened in the urban population in China using the Singapore data. So interestingly, the total number of primary open-angle glaucoma in China was estimated to be about 3.5 million. And the primary angle closure is about 4.5 million. And in total in China, we have about 9.4 million people with glaucoma in China. So they also estimate how many people in China will have a occludable angle or primary angle suspect. So this occludable angle number of people is around 28 million. So it's a very big number of people in China. They are really anatomically prone to angle closure. 30 years ago, one of our speakers or panelists, Leighton Condon, published a review paper that had been cited, I think, more than 500 times now. What he tried to do is he wrote up this major review and try to understand what is the issues in the epidemiology and population-based screening of primary angle closure glaucoma. So in another word, if in the population we have so many people angle closure, or we have so many people with anatomical risk, how are we able to identify these people through population-based or effective screening program? So when we discuss or talk about screening, we have to understand what is the gold standard we try to identify the screening program. So I think an overwhelmingly accepted gold standard has been defined based on static gonioscopy, which is pigmented trabecular meshwork, not visible in about 180. Some people define it as 270 degrees of circumference. Oblique flashlight test has been proposed as an easy to perform screening method to identify narrow angle cases. We did a study and tried to use slit lamp to provide a more quantitative measurement on the shadow on the iris in this oblique flashlight test. What we found is that if you define the limbo to limbo distance and also the length of the shadow more precisely, we can actually achieve a sensitivity and specificity about 76% and 80% to detect the eye or the people with 2 or more quadrants with pigmented trabecular mesh were not visible in static gonioscopy. So this, in another word, oblique flashlight test can be quite accurate in terms of identify gonioscopically close angle. Paul Foster and his group also published a paper in BJO. They tried to modify the conventional Van Herrick test. So they actually add 2 subcategories in the traditional Van Herrick test. One is 5% of the peripheral, 5% of the peripheral cornea thickness in the Van Herrick test. Another is 15%, I think, because in the traditional classification in the Van Herrick test, we only got less than 25% or 1/4 of the total peripheral cornea thickness. But now they have 2 more additional categories, 5% or 15%. And then they found out that when you use 15% peripheral cornea thickness as the indicator to identify gonioscopy angle closure, then the sensitivity and specificity is about 85%. But then if you use 5%, a more stringent definition, in the Van Herrick, in the modified Van Herrick test, actually this sensitivity and specificity can further improve to 91% and 93%. So they propose to use this modified Van Herrick test to screen, and then with the slit lamp to screen people with gonioscopy narrow angle. There are a lot of imaging technology has been proposed to examine the anterior segment of the eye. For example, the UBM and also the anterior segment OCT. To me, the UBM and anterior segment OCT, the significant advantage of this imaging technology is that this technology really be able to enable us to observe the oppositional contact in the dark environment. For example, the iridotrabecular meshwork contact right here in the dark environment. So then we really be able to make to see whether there's any this ITC is existent or not. But then we ran a study a couple years ago and tried to understand how frequent this ITC iridotrabecular contact happen in the gonioscopically narrow angle. We found out this ITC actually very common. So in the narrow angle eye. So if we try to use this ITC, we still are not really able to identify who are at greatest risk to develop angle closure glaucoma because they're so common. So hypothetically, we go back to the natural history of primary angle closure. So primary angle closure just developed from anatomic risk, and then Bobby Thomas study suggests that 22% of them in 5 years will develop primary angle closure, and about 30% of them will further develop primary angle closure glaucoma in 5 years. And laser PI as a prophylactic treatment is able to break this progression or conversion from primary angle closure suspect to primary angle closure. We all know that laser peripheral iridotomy actually is able to eradicate the pupil block. So after laser PI, the iris will be flattening and then the anterior drainage angle will be open again. So in Li1 eye study, we laser around 100 people, but then we observe or examine them again after 2 weeks. And then we found out actually this laser PI is able to open angle in 80% of the cases, but then 20% of the cases we may close after laser PI. But this is a very short-term result, only 2 weeks after laser PI. So the long-term efficacy, we are not quite sure. So going back to the number of people with angle closure suspect. Again, as what I mentioned before, 28 million people with narrow angle in China, and this laser iridotomy has become a very commonly performed procedure in US and also in UK. So the question is, should we laser all of these 28 million people? And what are the risk factors who should receive this treatment? So therefore, we run a study we call Zhongshan Angle Culture Prevention Trial in Guangzhou, China, and try to understand what is the long-term efficacy and safety of this prophylactic treatment, and try to understand the natural history of PAC, the conversion. How many people with primary angle culture suspect will develop primary angle culture in a long period of time, and what are the best predictor? So this basically is a 6 years long-term randomized trial, single center, and to prove the efficacy of prophylactic laser PI. So the paper was, we are quite fortunately, the paper was recently published 2 days ago in Lancet. Again, the study is first of all screening about more than 10,000 people with 10,000 people in the community. And then we identify around 900 people with bilateral primary angle culture suspect. We randomly assign one eye to laser treatment and the fellow eye as control. And then we observe and follow up them for 6 years. So about 75% of the participants remain in the study until the end of the study. So we use single YAG laser. We didn't do sequential argon and YAG. We just do single YAG for all these patients. If you look at the baseline characteristic, actually most of these angle culture eye, they have 3 or 4 quadrants with close angle under the static gonioscopy. So they're quite narrow. After 6 years, if we look at the endpoint in the control, in the treatment eye and in the control eye. So in the treatment group, actually in the endpoint developed in around, the endpoint developed in nine eyes, the endpoint developed in the treated eye, but not the control eye. But then conversely, the endpoint developed in the control eye, but not in the treated eye in 26 eye, like about 3%. So we can see that the laser did work a little bit, because if you look at this 2 by 2 table, then we do a survival analysis. In the treated eye, the endpoint reached in about 4 eye per 1,000 eye per year. So in other words, in 1 year, even among 100 eye, the development of the endpoint is less than 1. So we are talking about 0.4 among 100 eye in a year. So this number is about 8 per 1,000 eye year in the untreated control eye. So the endpoint did significantly reduce about half, but then the endpoint developed the event rate has been really, really low. It's only 4 to 8%, 4 to 8 per 1,000 eye per year. And also it's important to look at what kind of event we are talking about when we say event. So if majority of the event actually is only peripheral and anterior synechia. So there's very few cases develop acute attack, and very few cases develop IOP elevation also. So majority of the event, they are not then visually threatening, so they're just PAS. So what if you look at how many PACSI will be converted to PAC? As what I mentioned before, this number, a lot of people, actually the events we're talking about is only peripheral PAS. So the very low instance of PAC suggesting majority of the event there's no all these event they have no immediate threat to vision if you look at the control eye. So if you compare the treated eye and the untreated eye, the risk of developing the endpoint has been reduced, but a lot of event is on the PAS formation only. So putting back this into the population so that we understand what it really means to the population. So the overall annual risk reduction is only 0.38%. So we calculate, and then we can say that we actually need to treat around 44 people in order to prevent 1 case to develop new primary angle closure in 6 years. So if we try to estimate how many people will develop primary angle closure glaucoma, not just PAC. So we have to treat 126 cases prophylatically, and in order to avoid one case develop visual loss in 10 years. So this prophylactic treatment actually is not that targeting in another word. So based on this primary angle closure suspect, the primary angle closure suspect enrolled from the community screening. If we perform laser PI, so this may not be a good idea. So we conclude that this should not, a widespread use of laser PI among this particular group of primary angle closure suspect should not be recommended. Then we also try to compare those people who develop endpoint and those who didn't develop endpoint. And then interestingly, when you compare these two groups, the dark room provocative test that we believe this can be a good test to differentiate those people at greater risk, but actually is not associated with reaching the endpoint in this in this particular sample. So any significant long-term adverse event side effect. So if you look at the corneal endothelium loss and also the locus grading on the lens opacity, so again there are some difference between the treated eye and the control eye, but this difference is not clinically significant. So the take-home message from this a bunch of studies, primary angle closure has been very common in Chinese population, but the instance of developing primary angle closure among these primary angle closure suspects is really low. So given this very low event rates, we can say that the benefit of prophylactic laser PI is limited. So a widespread prophylactic treatment is not recommended. So this is a study group in China. Sorry for running out a little bit time to finish this presentation. So I will pass this to, let me see if Nathan is in.
Hi, Ming. Nathan is online, yes.
Okay, Nathan is online.
Yeah.
Nathan, sorry, I occupy some of your time. So can you just complete your presentation?
It's fine. So can you all see my screen? Mingguang, does my screen show up?
Yes, nicely.
Yes, your screen is
very nicely also.
Okay, good. Okay, good. Fantastic. So I'm going to speak briefly about glaucoma management in low resource settings. Some of these things are likely to change as a result of some of the data that we have recently and that Professor He has recently mentioned. So it's exciting. It's good for this webinar. We're going to hear some things that are quite new. So basically, in terms of a strategy for glaucoma in Asia, broadly speaking, our traditional recommendation has been to start in the clinics with clinic-based case finding. Economic models up until now suggested that population-based approaches are not cost-effective. In the age of 40 that are coming into our clinics, maybe to cataract outreach programs, those who are at risk of blindness for glaucoma. I would say that the contents of this slide has changed over the last week or so. We've had a paper accepted in Lancet Global Health that in fact shows with economic modeling that there's that it's very cost effective to do outreach screening for glaucoma in China, both in rural and urban settings, and both for angle closure and open angle glaucoma. So I would say that this advice that we should only be doing clinic-based screening has probably changed. Clinic-based screening is still important. I think in Asia today, many patients with glaucoma that come into the clinic are not identified because thorough examinations are often not done, especially in rural areas. But outreach screening does offer the opportunity of being the promise of potentially being cost effective. And I think this will be an exciting area for us moving forward to think about how to do those. In terms of screening for damage, I'm recommending the principal focus should be to look at the optic nerve. The emphasis on detecting patients with severe damage. There's very limited evidence showing the usefulness of visual field testing in people without field taking experience, whether it's the Humphrey visual field, whether it's simpler screening visual fields. In general, people who have not had those tests before tend not to do them very well. Sensitivity and specificity tend to be quite poor. The postoperative evaluation of the optic nerve will be important in patients with dense cataract. It's often going to happen in cataract outreach programs that we will miss glaucoma cases due to dense cataract. We should be sure that those programs incorporate looking carefully at the nerve after cataract surgery. It's also important that glaucoma screening and treatment be integrated with routine eye care. It's not going to make sense in areas of limited resources, particularly in rural Asia, to be doing a dedicated glaucoma program. Similar equipment and training can also be, since the equipment and training are similar, we should also build capacity to care for DR together with our glaucoma screening programs. DR and glaucoma should be screened together. We should also be doing careful pre-op evaluation before cataract surgery that will help to identify glaucoma patients. So cataract outreach can be a terrific opportunity to pick up glaucoma cases. In terms of treatment, speaking now for low resource areas, I'm not talking about Guangzhou or Beijing or Jakarta or Bangkok, but outside of the cities, barriers of opportunity cost, transportation availability mean that long-term medical therapy is probably not going to make sense in rural areas. In these areas, surgical therapy is likely going to be the most common type of treatment. We're interested in looking at this demand side. We've been speaking a little bit about the service side and what kind of screening and treatment services we should provide. But the demand side is also crucial. The question is here in Asia, what kind of demand is there for the treatment that we're offering? We sought to understand the kind of patients that were undergoing trabeculectomy in rural China. We looked at their pre-op characteristics and post-op follow-up in a total of over 200 consecutive patients at 14 rural county hospitals in Guangdong and Guangxi. We found that they tended to be operated too late. The median preoperative best corrected vision in the eye that had surgery was blind, 6/120. And in fact, over half, almost 2/3 of these folks were blind, less than or equal to 660 from glaucoma at the time of surgery. Their median IOP was nearly 40. The median cup to disc ratio was 0.9. Surgery at this point is going to offer a little benefit. So it's definitely a problem. It's an issue. It's a concern that patients are coming far too late to treatment, at least in rural China. And I think it's reasonable to expect that in other rural parts, underserved parts of Asia, it's also true that patients are coming too late. Coupling this now with evidence that outreach screening can be cost effective, I think perhaps a more proactive approach may be appropriate. In terms of follow-up, we also found poor follow-up after glaucoma surgery. Only 25% of patients in rural China returned after 2 weeks, and we lose the opportunity in those folks to maximize the outcomes by doing things like removal of sutures, by working with patients to reinforce their use of the post-op drop. So it's crucial that we have this poor follow-up. 4 different rural southern Chinese hospitals. Our interventions were cheap, simple, the kind of things that could easily be scaled. We had SMS reminders that were sent at 3 days.
Ethan, looks like we have some trouble with the bandwidth. Nathan, can you hear me?
I hear you. Can you hear me?
Yeah, we can hear you now. Please go ahead.
And can you see the screen as well?
Some of us, I think, can't, but I can see your screen, so please go ahead. Yes.
Okay, fine. So this, I'm saying that we found that the follow-up was very poor among people after glaucoma surgery in rural China. Only 25% came back after a week. So we did a randomized controlled trial with some very simple interventions, sending SMS reminders 3 days prior to their scheduled follow-up at a day, a week, and a month, and offering a free bottle of steroids worth about $5 at each visit. The main outcome was follow-up at 1 month, getting people to come back at 1 month. The results were that the intervention increased attendance very significantly. We could double the number of people coming back, from about 1/3 to about 2/3. We also found that telling patients to return at 1 month for suture removal was very significantly improved follow-up. We could double follow-up. When we looked at those two interventions together, offering SMS, the free drop, and also requesting them to return for suture removal, we had a really big impact. When we didn't do those things, it was 10% that came back. And among those where we offered both suture removal and our SMS free drop intervention, 65% would come back. So nearly 7 times improvement in referral with very simple interventions. This is a practical intervention for improving post-op follow-up that we could carry out in a number of low-resource settings throughout Asia. The total cost is less than $25. We could further reduce that using automated SMS messages, as we previously reported. We can compare that to the cost of nearly $700 for surgery in China. It's likely to be a very cost-effective approach. The problem is, if patients are already blind at the time of surgery, even optimal follow-up by itself is probably not enough. So how do we improve early uptake of surgery? Incisional glaucoma surgery seems to be unappealing to patients in rural China. They have to have inpatient treatment for an average of 3 days, a lot of cost and inconvenience. We're wondering if less invasive options might be more readily acceptable. We know that topical drop therapy is probably not sustainable, as we mentioned above. Tony Raolini and his co-authors have So we are carrying out a project now in China, which has been funded, comparing trabeculectomy versus SLT. We're trying to do a project like this in Africa as well, but the project in China is ongoing. Our main outcome is going to be the mean reduction in pressure at 1 year. It's a pragmatic trial. We all know, or those of us who are glaucoma specialists know, that the impact on pressure tends to be more from doing a trabeculectomy compared to an SLT. But in our study, those who refuse therapy will still count. And so our hypothesis is the mean reduction in the group receiving laser is actually going to be greater than that for trabeculectomy due to a high refusal rate among TRAB patients. Our hope is that this work can lead to a broader adoption of cheaper lasers. And in fact, we're working in a project now funded by the EU to develop less expensive lasers that could be used throughout Asia to provide cheaper laser treatment if we can prove that it's more likely to be accepted, more effective. So in summary then, in terms of an approach to glaucoma in areas of limited resources, such as rural Asia, there's an emphasis on good training and comprehensive exams to relatively less expensive, that actually doing outreach screening for glaucoma is cost effective and probably should be considered as part of our approach. Treatment in these settings is likely to be surgical because of the problem with drops being too expensive and impractical. The best surgery in these kind of settings needs to be acceptable to patients. We clearly see that incisional surgery, and the data we have, is resulting in far too late uptake. People are largely blind by the time they have their surgery. We're hoping to prove that laser could be a safer, more effective, and more acceptable option. And finally, there will be a need to invest resources to promote post-op follow-up. We've shown there are some very simple interventions under 25 US dollars that can be very effective in getting patients to come back after surgery. Thank you very much.
Thank you, Nathan. Julian, if you're ready, I'm going to make you the speaker now.
Okay, everyone, can you see my PPT?
Yes, we can. Please go on.
Okay, let me begin. Okay, good afternoon, ladies and gentlemen. I would like to discuss with you the management of glaucoma in China, the challenge and opportunity. I don't have financial disclosure. Look at this table. The population in China is almost 1.4 billion, and glaucoma patient is 13 million. And look at the 2012, the ophthalmologist was registered is 28,000. That means almost per 100,000, less than 2 people. And glaucoma specialist is about 1,000. So let's take a look. The largest ophthalmology center in that is my center. The ophthalmologist is only 239, glaucoma specialist 16, but we face a lot of their patient. The outpatient clinic is more than 10,000 per year, and we need to do their glaucoma surgery about per year 3,000. That means huge number of glaucoma patients with lack of glaucoma specialists. Let's look at the prevalence of glaucoma in China. Mingguang already showed that 2.58 and POAG is 1.4 and PACG is 1.02, almost the same with the prevalence of glaucoma worldwide. However, the glaucoma in China a little bit different. The PACG is the main type, and most of the patients came already in the late stage. And not everyone has a health insurance. That means more challenges for doctors and less support for the patient. For the academic side, China, we have expert consensus on diagnosis and treatment for glaucoma since 1987, and we are revised regularly. And we also have all kinds of the PPT can be followed, such as AAO, EGS, APGS. And look at this picture. This is 10 books of WGA consensus series. And we already translated and published in Chinese version. That means Chinese ophthalmologists can catch the same pace with international level. Now, I would like to talk about several issues with you, which is Mingguang suggests me to do. The first one is acute primary angle closure in China. We can simply call APAC. In Western country, I know most of the APAC can be end up successfully by LPI or the iridoplasty, but Chinese APAC always came late, sometimes with a recurrent attack. That means most of the patients cannot successfully control IOP by the LPI. Some of them need trabeculectomy or another surgery to control the IOP. But now we gradually realize and accept that phaco emulsification is more effective in IOP control. And the clear lens intrusion is preferred in early primary angle closure, can be confirmed by the Lancet. And now similar clinical trial has been running right now in China. We call China Eagle study, and hopefully we can get more evidence to support that the lens intrusion can be used to treating APAC in the future. Now let's talk about a little bit MNC in China. Everybody knows that the MNC is so important, especially in Chinese patient, because we have a higher success rate. However, MNC is a shortage in China already, almost 2 years. I hope everyone can know this and speak out this news, and hope someone or some company can help us to solve this problem soon. Now let's talk about a little bit mix in China. Mix is the most fascinating issue at present time. He has all kinds of the surgical subtypes such as trabecular, canaloplasty, iStem implant, hydrous, cypress, and the Zen gel. However, the mixed surgery have been used in Western countries more than 10 years, but still haven't entered China due to complex approval process. The trabecular and AB or GAY have been performed in Beijing area for 2 years. The Zen is expected to enter China this year. But look at our center. This is the biggest center in China and ranking the first in Academy of Ophthalmology in China. The AB and the GAY just started 1 month ago in here. Now let's turn to the refractory glaucoma in China. I wrote it down here. All of this is a refractory glaucoma. However, we always face the case more severe than this, such as this is even though it's no sight, but the patient feels so painful, MVG, and a very high intraocular pressure. And then this bullous keratoplasty plus the MVG, and this is Sturge-Weber syndrome with the extensive scleral staphylinoma. And this is ICE, but with a very shallow peripheral anterior chamber. So very difficult cases. For example, this guy is the only right eye have a 2 orientation, have a side. But the pressure very high and already done 2 times trabeculectomy. And you can see the picture that the whole eyeball have a scleral staphylinoma, except their inferior nasal part, a little bit healthy conjunctival and the scleral, which is supposed to for us to do the tube shunt implantation. This is another guy, is 56 millimercury intraocular pressure, and very painful, and he has MEG and cataract and very shallow peripheral anterior chamber. And we look at the whole eyeball, they also have the scleral staphylinoma all around the eyeball, except the supratemporal a little bit of space for us to do the surgery. So for all kinds of these very severe cases, we need more technique and an instrument to help us. However, in China right now, the situation like this. Glaucoma during its device, we only have armored valve, no valve valve, and the poor glaucoma implant is expected to pass CFDA approval this year. We do have the cyclophotocoagulation, the CPC. We have endoscopy and transscleral, but we don't have micropulse CPC. I think the micropulse CPC may be very useful for that cases I just mentioned several times, that with scleral staphylinoma patient. And we do have ultrasound scleroplasty UCP, just came to China, but it's very expensive so far. Now let's take an example. Look at the current status for management of the neurovascular glaucoma, NVG, in China. I mentioned this because more and more NVG patients came to clinic due to diabetes mellitus and hypertension. But the good news is that we will have a consensus on treatment of the NVG will be published in next month. And this consensus, written by me and past several discussions by Chinese Society of Glaucoma and Retinal Disease. So this is a really good thing for us to follow how to treat the NVG. And we already know that PRP and anti-VEGF is the first choice for original disease. And anti-VEGF is the key before surgical treatment, such as a trabeculectomy, express RMAT, and CPC UCP with the anti-VEGF injection. I take a 2 examples for you. This is a typical MVG before anti-VEGF injection. You can see very severe inflammatory response under the UBN. And after anti-VEGF injection, you can see the MVI regress, but the IOP is still very high. And we performed the AMET2 for him and get very good result. But now more and more Chinese doctors are become skillful with the surgery, and the outcome of the MVG was greatly improved. And the anti-VEGF product in China market right now is the Avastin is off-label use. Lucentis is expensive, but partially covered by health insurance. Composite is developed by our own country, and the phase 2 trial being performed in USA right now. And Alpha-Basset is recently available in Chinese market, and we have another small molecule will be developed for the eye drug for use there. MVG will still under their investigating. Now let's take a little bit talk about clinical researches of glaucoma in my center. And this video shows that in my center we have clinical research center. We are building EDC system right now, and we do have professional biostatistician. I never can pronounce these words right. And hopefully we can build a very good platform to help to do their clinical research project. So lots of multi-center clinical study have been done, and this table show we have some of the ongoing clinical researches in glaucoma, such as TVT study, and the nasal peripheral iridotomy plus nasal peripheral iridotomy for PAC, and artificial intelligence assist glaucoma evaluation, and the ICE multicenter study, and also have the glaucoma with impaired coordination, the project. And the night trainer is between my center and Moorfield Eye Hospital to look at the SLT and the medical treatment for the OHT and the early POAG. So a lot of the ongoing project is running right now. I take an example, we look at the AI in early diagnosis and screening of glaucoma. We have one multi-center studies, it just finished, to compare the anterior chamber perimeter between open and narrow angle subject. The aim is to provide data for angle assessment algorithm development in the future. And by using deep learning system, based on the founder's photo, Ming Guang developed of AI algorithm for detection of possible glaucoma, achieve 100% their accuracy. In my team, we also released APP for visual field interpretation, we call iGlaucoma 1.0. The neural network algorithm has been inserted in the APP, and now you can scan the visual field report with a phone camera or the computer and make a quick diagnosis to tell you glaucoma or not glaucoma. And the multi-center clinical trial is running right now to verify the efficacy of this algorithm. We also combine the visual field and the OCT to construct the glaucoma screening platform we call iGlaucoma 2.0. And step by step, we will combine anterior and posterior segment and add follow-up data. We plan to develop smart diagnosis and decision-making platform. In order to promote development of glaucoma diagnosis algorithm, we released the largest open access annotated glaucoma fundus photo database in the last year in the MICAI conference. And now besides glaucoma, we also released AMD and the PN dataset and more on the way. Now I will take 2 minutes to talk about publicity and education in China. Chinese Glaucoma Society is really active. We have a congress is held annually with a lot of lectures and other issues. We have training course, we have seminars, and during the World Glaucoma Week, the Chinese ophthalmology, especially the glaucoma specialists and doctors, really take active part in various activities, including conference, lectures, online consulting, just like ours is right now in webinar and a free clinic. And this is outlook of the 2 days ago on the World Glaucoma Week in my center. You can see very cloudy and very busy. So let me summary why I talk about. Although faced with the giant challenge from glaucoma diagnosis and treatment for such huge population, Chinese ophthalmologists are sparing no effort to improve the quality of health care of glaucoma. And advanced progress in clinical researches have been achieved. Cutting-edge studies covering various aspects of glaucoma are carried out. We hope that there will be more opportunity for Chinese doctors and scientists to communicate and share the work with the world. Thank you very much.
Thank you. Thank you.
Thank you so much, Sulan. Great job. Great presentation about tertiary care in glaucoma for glaucoma service in China. Now, thank you very much. And now we just have a couple of minutes for the audience to ask questions. So can you just read the question for us?
Is there any role for GATT in China, especially in rural areas, given the low cost, fast operating time, and relative safety? This is what Karen Hong is asking.
So can I pass this question to Sulan?
Hello? Ask me the question? Okay. What's the question?
Is there any role for GATT in China,
okay,
especially in rural areas, given the low cost, fast operating time, and relative safety?
Yeah, in my center, we just got this GATT 1 month ago. I just tried yesterday one cases. It's very useful, but it's very expensive right now. He take a lot of money. I don't think he can use as popular in the rural area in China so far.
So how much the patient have to pay for the consumable in China? I just try to understand.
The GATT, they have the micro tube. They cost 1.6. How much money? 1.6, how to say that? 16,000. So just for the tube, and it cost the surgical cost and the anesthesia cost almost 30,000 for one surgery. Too expensive.
So we are talking about around say like $5,000 US. Consumable for the GATT surgery. Yes, 5,000, around 5,000 US.
Yes.
Around 5,000 in total for the consumable. Wow, that's very expensive.
Very expensive, yes. So the mix is very good, but just so far it's very expensive.
Okay.
I think that's all. We don't have any further questions. I think there is also one more from Karen Hong. What will be the clinical applications of AI or deeper learning apps that you have developed? Again, I think this was Julian. What will be the clinical applications of the AI and deeper learning apps you have developed?
So maybe I can try to answer this question. So first of all, the AI and deep learning is not going to replace doctor. So we're not going to take over job from doctor. So I think clinical application of AI and deep learning is mainly on the settings where the eye professional is not available. For example, setting up a glaucoma screening, AI screening facility in the community health center where there's no eye professional, that would make a lot of sense. Because at the moment, the deep learning and classification is very on a simple classification on the glaucomatous optic disc change. So that is, in at least five years time, the AI is not going to make significant impact in the ophthalmology clinic. So any comments from you, Shulan? Or
I agree with you. So far, we're still on the study, and the first step is to help the doctor to diagnose the early glaucoma, but not ready yet for the patient in the public. At least 5 years.
There's a lot of excitement about AI, not only to replace doctors, but also augmentation. And this can be very simple AI that can be integrated into an electronic medical record that can allow a physician, even in a low resource setting, a rural 县级医院, a county hospital, that can help to guide their treatment, suggesting in certain cases, if you report a narrow angle, you should consider a PI, certain medications, remembering to ask about contraindications. There's a lot of role, I think, even at the current state of AI, to do that kind of.
Hello?
No, sorry, Nathan, your voice cut off.
Physician augment guide.
Very good. I think we're getting close to 1 hour now.
Yeah,
Yes?
I think we are. Yeah, there is one last question if you want to try, but otherwise,
Okay.
yeah, we're out of time really. Should I read out the last question?
Go ahead and tell us the last question.
This is from Song Yunhei. And how do you think the clinical research is running in China? What should be improved and how to improve the quality of studies?
Good. So can I pass this question to Xiulan, because you're the director of the research center.
Hello?
Yeah, Xiulan, can you try to answer the question? What can be improved?
How do you think that clinical research is running in China? What should be improved and how do you improve the quality of studies?
In my center, the clinical research center is running really good because we always follow their international standards. We do have their how to say that ethics committee.
Ethics committee.
We have the academy committee to help to how to say 它的把关还是什么之类的东西。
To guarantee the quality.
Yeah.
Good. So can I ask Nathan to answer also?
I can understand.
From
yeah, sure. I mean, hello?
As a foreign researcher working for many years in China, I would say that the Chinese research enterprise is very robust. If we want to expand even further, I would encourage a couple of things. Some of the research support things like IRBs, ethics committees that meet more regularly and can more quickly act on research applications, giving more of a role for younger people to take more senior roles in research, I think can be helpful, to take a more active role in research. It can be a bit hierarchical. And, I think it's important also for there to be more government support, not just for basic science, but also for clinical science, epidemiology, and action research. Those are all suggestions to further improve the situation, but I do think anyone would agree that eye research in China is quite robust. It's moving very quickly, and it's been amazing to see how it's developed over the last 10 or 15 years.
Yes, I also I quite agree with Nathan, because I'm running clinical research in both China and Australia. The significant advantage in terms of running clinical research in China is that the labor cost is much lower. So in China, actually, we have nurses dedicating for example, we have one nurse dedicating for visual acuity and visual function testing only one task. So, but this is too just impossible in Australia. Running a clinical study in Australia, enrolling about 100 people can take about 1 year to complete the enrollment. But in China, this can happen in 2 weeks or even 1 month's time. So this is, I mean, the efficiency and the labor cost is significantly low, much better in China. But then, as what I agree with Nathan, I think how to improve the quality and a little bit like more on the governance and quality control would be very helpful for further improvement in the quality of work in China. Good.
Great. I think so. We have now run out of time completely. Thank you so much, all of you panelists. Thank you for your time. I know you, Nathan, especially, it's very early in the morning for you, and all of you have very, very busy schedules. So thank you so much for making time for us, and I really hope you've enjoyed this 1 hour, all of you attendees. We'll be sending out a small survey after this is over. Please do send us your comments. And that's about it. Thank you. Thank you so much.
Thank you so much. Thank you very much.
Welcome.
Thank you, everybody. Thank you.
再见。
再见。